without further ado, I'll hand over to Denis for learning from COVID-19 remote consultation in outpatient services.
Okay, thank you very much, Richard. You chaps can all lunch away. I better not, otherwise you won't understand me. Thank you for inviting me to come and talk today, and I'm here primarily in my role as chair of the Outpatient Development Group. Now, this was a group that had started even pre-COVID with the idea of looking to see how we could transform our outpatient services for the benefit of everybody, particularly our patients. Then, as we all know, we've been hit by an unknown quantity, COVID-19. Nobody knew what was going to happen, how best to deal with it. So we've all had to live and learn as we've gone along. And the Outpatient Development Group was tasked to take on the role of looking to see how we could rapidly improve the services and access to care for patients during the pandemic. So while I'm leading the Outpatient Development Group, I think I do have to pass on my thanks to many, many, many team members who have stood up and worked very hard to get things changed in a very rapid way. So the main development that we're going to talk about today was the introduction or the expansion. We already did have some remote consultation ongoing, although at a very low volume level. But we quite rapidly had to expand that to make it available, not only from within the trust, but across our community services. And this has been picked up in varying degrees by services, and we've all learned and tackled this as we've gone along. So teams have had to reevaluate the way that they worked to try and enable remote consultation. And I'm going to talk about remote consultation rather than just video consultation. That includes telephone consultation. And also we've looked at various ways that we could digitally monitor things. And hopefully we can take a lot of this learning forward for the longer term. I think lots of people were surprised about what remote consultation could offer, can offer, and there's some spin-off benefits. I'm going to put a caveat on that. It's not going to be appropriate for every consultation. There is undoubtedly still a need for face-to-face consultation in particular groups, and we mustn't lose sight of that. But if we can deal with the problem and address the concerns of our patients and coordinate their management remotely, why would we drag somebody up to a hospital? If you think about it. So I work at CIC predominantly, and we have patients that might have to come from Whitehaven, Egremont, etc., Appleby. If they are working, they're going to have to take time off work. It's probably going to have to be a whole day off work. They're going to have to travel. They're going to have to park. They're going to have to wait. And that might be a relatively short consultation with a clinician. And we need to ask ourselves, for whose benefit are we dragging them all that way? I mean, one of the first drivers to remote consultation was, one, to be able to maintain contact with patients, but secondly, to reduce the footfall on the acute trust as cases ramped up and we needed physical space, because we had to utilize some of the physical outpatient space that had to be converted into acute inpatient assessment areas for COVID patients. I think an awful lot of our patients have accepted remote consultation quite easily, and they themselves continue to see the benefits of that. And in the paper that you can have access to, certainly from the Attend Anywhere monitoring, it documents the benefits that the patient see with this process. They don't have to organize childcare, they don't have to take time off work, they don't have to travel, and the number of miles and costs that they can save is significant. Moreover, by not sending clinicians all over the county, we can save on their travel. The pace of change had to be quite rapid. And I think we were only able to do that because traditional bureaucracy was taken out of the equation to some extent. And I think I have to applaud the resilience of our staff who had adapted to the change to support our patients' well-being. I think remote consultation has moved into areas that people traditionally might not have thought possible. You know, early supported stroke discharge, we can't do that remotely. Well, I've had feedback from the early supported discharge team who, again, while it's not for everybody, they have been able to save probably about 12% of their consultations out in the community to the benefit of their patients that in the thick of COVID, they might not have been able to have any access to at all. It's not come without its own problems. It's thrown up some quirks that we've had to deal with or might need to continue to deal with. For example, it needed the cooperation of our GP practices that we might undertake a remote consultation, and I'm talking primarily from the acute sector here, but the patients need some tests so that they've been able to provide that remote phlebotomy for us. We needed to work out ways of how we could get remote prescribing. If we're seeing the patient on a video consultation or a telephone consultation and they need some medication, how do we get that prescribed rapidly? And similarly, the remote or home delivery and provision of drugs, we had to look for new ways of that. And then again, we had to overcome some of the traditional bureaucracy, i.e. the need for wet signatures. There are some services that hadn't or haven't in the past worked without a wet signature. I think the modernization of technology and the fact that, you know, in all of our everyday lives, we provide confirmation of who we are and where we are, etc. We didn't do that remotely, and yet within the health service, we were still wanting a piece of paper with a wet signature on. So we have been able to implement some fixes in the short term to enable that, but we need to probably continue to explore some of the hurdles that we need to overcome to look for a more sustainable method in the longer term. So I'm gonna stop there now. I hope I've set the scene for what went on, and it may be that people would be interested in more specifics or have specific questions, or perhaps even would like to feed back some of the concerns or benefits or advantages that they've seen with remote consultation.
Sorry, I was on mute there. Thank you, Denis. Sorry, I thanked you on mute, but I'll thank you off mute now. Yeah, no, that was very interesting and a sort of a useful overview of what's going on. I'm gonna dive in first and claim chair's privilege. I just wondered what the sort of patient experience feedback was on this process. Obviously, COVID's made it very an unusual situation, so it's maybe not a fair trial, but how have the patients found it?
I would say that the vast majority of our patients have found it very helpful, and in many cases preferable to some of the traditional consultations that we had. It depends on the circumstance, and I would reiterate, if you need to be examined, there are some specialties that it's not always going to be appropriate for. But for those, you know, if it's about discussing results, organizing results, discussing investigations, etc., that can all happen remotely. And the patients themselves, certainly we have very good data from the Attend Anywhere service, and they regularly get feedback from the patients. So we've had they comment on saved traveling time. It's more convenient. It's taken less time to have that consultation. They don't have the waiting in an outpatient area waiting to see the consultant. It saved them money, and they didn't have to necessarily take somebody with them if they had some frailty issues or traveling issues. And I think that's something that we do have to remember. Most of us who are at work are probably fairly agile and have access to transport. An awful lot of our patients have significant difficulties in transport.
Yeah.
And if they have to use public transport in the middle of COVID, that was a major hurdle. I think if you look at it from an employer's point of view, now that people are getting back to work, what would you rather your employee did if they had a hospital appointment? Take the whole day off work and travel 50 miles each way with a cost, not only to the patient themselves, but to the business? Or if they have a 15 or a 30-minute consultation, do you just want to give them those 15, 30 minutes out of work where they can go and talk somewhere privately? I don't think it takes much to recognize the benefits there.
Yeah, no, that makes sense. So actually there's a question in the chat leading on from that. So will or have the services gone or going back to what they were before?
Lots of services have maintained a lot of their remote consultation. Indeed, I think the NHS nationally recognises some of the benefits, and now there's a national drive to have at least 25% of consultations done remotely. That's across the board. Some clinicians are reverting back to their traditional way, but I think it's incumbent on us all to demonstrate the benefits for our patients. I think that's the key. We should be thinking, what is the best way for the patients? If you look at traditional outpatients, I would question whether they were designed around the patient. I think they were more around the clinician for their convenience. You go and sit in a room at a set time, don't have to think about how you do it any other way. Turn up, patient turns up, you see them, and then you go away again. But I think moving forward, there are so many other advantages for the appropriate case.
Yes. And how have you? There's another question here about sort of digital literacy. You know, do you think that is a barrier to some people at the moment?
I think that has been a concern that has not always been borne out. I think the evidence now is that the vast majority of people have access to certainly telephone, and I often get it thrown at me, oh well, little old ladies or little old men, they don't know how to use a mobile phone. Well, I think they do, because their families have already provided them with a mobile phone so that they can keep in touch. And certainly through COVID, they were provided with that so they could keep in touch remotely. So I think there's already a mechanism in place. Video consultation may not be for everybody, but there are ways around that. We are currently trying to address access for video consultation facilities. If a patient doesn't have it, do they still just have to revert back to the traditional consultation? Within the community, we're setting up various community hubs so that they could go and attend locally and have access via a video consultation facility there.
Yeah, thank you. And we've got a comment here. Well said, Dennis. We need to design services with the patient need foremost. Difficult in these stressful times, but rewarding. There is a question with that one. Any data on the DNA rates on face-to-face versus remote?
I'm not going to try and quote reliable data here. Because in some specialties, we've had high DNA rates in certain specialty groups. And I'm talking about, underprivileged areas. I've already mentioned, if you can't get transport, then you're not going to come to your clinic appointment. Certainly during the thick of COVID, it was pretty rare not to be able to get somebody on the phone or with a video consultation. Now that people are back at work, it's becoming a little bit more difficult if we, and I think it's incumbent on ensuring that we, the clinical teams, have the correct numbers available. Now, one problem that has been highlighted, and I haven't found a fix around this, and if there are people out there who can tell us how to do it, I'd be grateful. when we ring out from the hospital, the number is withheld. And I don't know what you do about phone calls you get on your mobile phone with no identified caller, so they don't answer. So we have to usually leave a message and then ring back again a short while after, and it'll pick it up. It's understandable. I have asked, is there no way that when we ring out, it can give some sort of ID as to where it's coming from? So if people have got ideas or solutions around that one, I'd be extremely grateful.
Actually, yeah, that's a good point, Dennis. I before I worked here, actually, I was at Sunderland, and we had exactly that problem. Actually, a lot of it came round from either people not knowing it was us phoning, or actually we had a technical problem there in that it blocked up a lot of the outgoing lines, so the system broke down from that. But I'm sure there must be technical ways around that. We have another question. Has it made outpatients more efficient, e.g. running better time, seeing more patients in time available, and have you looked at data on that?
Okay, we haven't looked specifically at the time factor, and I would say from my own personal experience, I don't know that remote consultation necessarily gives you a quicker consultation, certainly for new patients, because we have to address the consultation in a slightly different way to achieve all of the information that we need. Moving forward, I think an awful lot of that could be addressed by technology, by getting that information to us before the consultation in a better way. We do have some limitations with our digital technology in the acute trust. I don't think we're anywhere as near the efficiency that some of our primary care colleagues have, because they have an awful lot more information available to them digitally, I think, than we do. It certainly doesn't take longer, and I think keeping to time is probably better.
Yes. Okay. And actually, one thing I was wondering as well, you know, from the patient perspective, historically, there's been the GPs and there's been the hospital, so there's quite a clear difference between the two. I mean, this opens up a world of possibilities in terms of what we can do and how we can do it. But if we're starting getting, you know, sort of hubs for phlebotomy and other services out there, and obviously you can see people remotely through the GP surgery, do you see those barriers maybe breaking down?
I think so, and I think that's why we are now termed North Cumbria Integrated Care, because the driver is to have much more of a global health economy rather than a fragmented one.
Yeah, that makes sense. Yes, I think there's a few suggestions flying through the chat here about, you know, when you send remote consultation appointment letters out, there could be a warning that the phone will come up with withheld or unknown. And I'm sure there's various things that could be done to help that.
Yes, it doesn't seem to make much difference about that yet at the moment. I mean, I had a patient yesterday, and we eventually got through to him, and he said, "Oh, well, I put a block on my phone for for calls," which was we can't control for that.
Yes, it's a difficult one. It's certainly one that we didn't manage to fix during my time at Sunderland when I was involved with this. I think there was also a point about sort of patient confidentiality.
Yeah, some people have had concerns about how do we know we're talking to the right person.
Yeah.
I think that we just need to be a little bit more circumspect when we make that call, that we undertake some checks. You know, can they give us their date of birth and address and that sort of thing before we start. I don't know that necessarily is any greater than going to an outpatient waiting area and shouting somebody's name and the wrong person come in, because I've had that happen.
Yes, again, yeah. I think that's very true. And have you found that this has worked well with sort of vulnerable groups such as the elderly, who usually bring someone with them? Have you managed to coordinate calls where the sort of the carer, for example, is with the patient? And
yes.
Yeah.
I've done that recently. In fact, yesterday, the daughter was in attendance with the patient to help. We've even been able to do it with people who have disabilities, with deafness, having their sign reader there. The Attend Anywhere platform actually can do that, and they don't even have to be in the same place, because you could have multiple callers dialing in from different sites. So you could have the patient, their relative or advocate or friend being somewhere else. You could have another doctor in a different hospital having a multiple disciplinary type consultation. And indeed, I think we need to look at expanding that opportunity for the longer term. So rather than, say, for example, my specialty is gastroenterology, and I liaise with the tertiary centre in Newcastle for many cases. So rather than me necessarily having to refer the patient over there, go through that process of referral, and then the patient getting an appointment, then having to travel to Newcastle, why couldn't we just bring them into our consultation when I'm reviewing the patient, knowing that I was going to have the questions for that specialist could join that consultation, and we could jointly manage the patient. Saves them time, saves me time, saves the patient time.
Yeah, no, definitely. And yes, just another comment, sort of, have you sort of looked at protocols like banks have for doing checks on who you are when you're talking to people?
Sorry, say again?
Have you developed any sort of protocols like banks have for doing the checks when you're talking to the right, to make sure you're talking to the right person?
All right. Well, it can only be simple checks that they're going to be able to give information. I mean, I suppose we could send out sort of pins with the letters if we really wanted to do that, but I think somebody's already put in there that, you know,
yes,
our specialist societies and GMC have given guidance about this, and it'd be pretty big. I mean, the patient knows that they're getting a call. If they're going to answer because they know how they have. If it was somebody else who got through to the wrong patient, the wrong person, they're likely to say, well, no, I wasn't expecting a call, because we always ask, were you expecting the call? But for instance, with the Attend Anywhere video consultation platform, they're given the link to dial into. So it's only that patient that it would have the link. It's not a generic link that's sent out to.
Yes, yes, and I think it's probably fair to point out as well that the current or the old system isn't watertight either, because I mean I've known of examples of letters going to the wrong addresses and being opened, for example. So it's very difficult to produce something that's absolutely 100% watertight all the time, although that's what we're always aiming for. But yes. Oh, well, thank you, Denis. I don't think we have any more questions at the moment that I can see. But there is the copy, obviously, of what Denis has been talking about today, and there's a link in the chat for that. We will be hosting future Lunch and Learns we're hoping late August and then into September. We're having a bit of a break for the summer holidays, and we'll be advertising dates for that in due course. Subjects include, I think, flexible working, which is one that people often have a question about, and the team time sessions also that the NCIC offers. So those are just a couple that we've got lined up for the future. But for now, I hope you've all enjoyed your lunch break and found this informative. I certainly have. And I'd just like to finish by once again thanking Denis for being our inaugural speaker and kicking off what I hope will be a long series of talks. So thank you, Denis.
Thank you for inviting me. I've enjoyed it.
Yeah.
I hope it's been helpful.
Definitely. Thank you.